Good afternoon, everyone. Welcome to this week's Department of Medicine meeting. We're very honored today to have an international speaker, Professor Gary Lee from the University of Western Australia. And I'm very excited to hear his talk on pleural disease. I'm going to hand over to Professor Ketan Dada to introduce Professor Lee, and Professor Dada will chair the session this afternoon. So thanks. Over to you, Ketan.
Thanks so much, Graham, and to everyone, good afternoon. It's a singular privilege and honor to welcome Professor Gary Lee to present at our Grand Round today. For those of you who don't know him, he's a global research leader in the field of pleural diseases and has previously been the keynote speaker here at our South African Thoracic Society National Conference. We were contemporaries when we both did doctoral and postdoctoral training in the UK. He is a preeminent clinician scientist and pulmonologist, and his work has challenged and disproved decades-old conventional practices, has saved thousands of lives, and has improved patient quality of life in many aspects of pleural diseases. He was recruited to the University of Western Australia in 2009, where he set up the Southern Hemisphere's first pleural program at the Sir Charles Gardner Hospital. He has a huge CV and has over 250 publications, and I'm not going to go much through his CV, except to say that he's a regular feature in The Lancet and in the American Journal of Respiratory and Critical Care Medicine, which is the highest ranked journal now in the field of respiratory medicine, and out of interest, tuberculosis as well. He has contributed substantially to capacity development, inspiring global acceptance of pleural medicine as a new subspecialty. His talk today is entitled Pleural Diseases, What's New, Fun, and Practice Changing. The talk will be delivered in 3 parts. The first part will be on pneumothorax, the second on malignant pleural effusion, and the third on pleural infection. Each part's about 10 minutes, and we'll have a 5-minute break between each part so you can ask questions, and you can please post your questions on the chat group or raise your hand. And that said, over to you, Gary. Thank you so much.
Great, thank you. Let me just bring on my slides. Sorry, Ketan, can you see the slides now?
Yes, we can see it all up nice and clear. Thanks.
Thank you. Good afternoon. It's been quite a few years since I last spoke in Cape Town, so it's a great pleasure today to talk about pleural diseases again with you. As Ketan was saying, I'm going to try something I haven't tried before, but when I sit on other people's Grand Round, listening to 45 minutes or 50 minutes of talk, it's quite a long time. So I'm going to divide the talk into 3 sections. I'm going to give you a concise summary of how I approach these conditions in my daily practice and why. It will be my way of doing things, but by no means the only way. It's not going to be a comprehensive literature review, because I would like to leave some time after each section for questions and for interactive discussions. If I'm allowed at the very last minute or 2, I would like to share with you some of the research that we have been doing that I considered fun and practice changing, and show you how these can be integrated into your very busy clinical schedules. So if you do a Medline search or PubMed search and use pleural as the title word, you can see from 1810 to 2021, there has been a very significant surge of number of publications on pleural diseases. But more importantly, in the last 15 years, we have seen a very significant number of very high quality clinical studies in all the high profile journals that has really changed the practice of pleural disease. But as Graham and I was discussing before this, there are still a lot that we don't know about Pleural disease, and clinical Pleural care is often based on historical teaching that has never been objectively evaluated. Many of these teachings have been found in recent studies to be ineffective and some of them even harmful. So the lesson of all these is that we must critically evaluate many aspects of our common clinical practice. And most of the advances we have in recent years centers around achieving better outcomes with less invasive approaches in almost all aspects of pleural diseases. And perhaps pneumothorax is the first one. This is a New England Journal paper that I was part of that challenged and disproved some of the conventional concepts that we used to manage primary spontaneous pneumothorax. So I'm going to start with that in my talk. Now, most of the literature on pneumothorax management focus on what size of drainage device to use: large bore tubes, small drains, simple aspiration with needles. But perhaps the most fundamental question we should ask is, does primary spontaneous pneumothorax needs to be drained? This started from several papers in the 1960s. This particular one by Professor Peter Stradling from the Hammersmith is the most cited one, about using conservative management, which is no drainage at all for spontaneous pneumothorax. What do we mean? If you think about pneumothorax as a hole in the balloon, what we want to achieve is for the edges of the holes to come together and for it to heal. But what are we actually doing, if you think about it, in everyday clinical practice? We focus on treating the chest X-ray to make the X-ray looks better. And in so doing, we put the chest drain into patients so that the lung expand, so that the X-ray looks better and we feel better. But you can imagine quite easily, in so doing, we are pulling the edges of the hole furthest apart. And God forbid, the surgeon comes along and put the patient on suction, and the constant bubbling of air through the hole, it is a miracle that any of the pneumothorax ever healed. So what is the alternative? One potential alternative is to let the lung stay down. And in so doing, the edges of the hole will be in its closest proximity, and it might just potentially be able to facilitate faster and better healing. It's with that in mind that the primary spontaneous pneumothorax trial was conceived, and it involves 39 centers across Australia and New Zealand, where we randomized 316 patients to conservative or interventional treatment. The most important number you need to remember was that 85% of those treated conservatively, which means no drainage, no aspiration, were successfully managed without ever having had an invasive procedure. Of course, that does mean that 15% of them still have required a procedure. So in the trial, which is the largest so far to date on primary spontaneous pneumothorax, all of the patients receive analgesia and oxygen if they're hypoxic. In the interventional arm, they received a small cell Dinger drain no more than 12 French gauge. And if there's no bubbling and the lung fully expanded after 1 hour, the drain was capped off. A repeat X-ray at 4 hours, and if the lung remains expanded, the patient is discharged. If not, then they're admitted to the hospital under the attending team. In the conservative arm, the patients are observed in the emergency department, X-ray repeated in 4 hours. And if the patient is clinically and radiologically stable, which in particular means that they can walk around the emergency department when you examine them, they are discharged. If they're unstable, they're referring to the attending team for admissions. Unstable means that if they're hypotensive, tachycardic, tachypnic, hypoxic, or importantly, if the X-ray shows that the pneumothorax is enlarging. This is the Collins method of quantifying a pneumothorax, measuring the size of the pneumothorax from the apical, middle, and lower zones. And by Collins equations, this translates to a 64% pneumothorax. And we're showing this because this is the average size of the patient's pneumothorax in the trial. So these are not small pneumothoraces. And the primary outcome shows that conservative management was not inferior to the interventional drainage in the proportion of patients with full lung re-expansion by 8 weeks. If you look at the secondary outcome, there was no difference in time to symptom recovery, i.e. no pain and no analgesia, whether you drain the effusion or not. But the rest of the secondary outcomes were overwhelmingly in favor of the conservative arm. If you drained the pneumothorax, the patient spent more days in hospital, more days off work, more likely to have persistent air leak, more likely to require surgery, and have more adverse and serious adverse events, usually related to chest strain and surgery, and report a worse satisfaction outcome. Even more interestingly, those who have a drainage, that interventional drainage, 17% of them have had a pneumothorax recurrence by 12 months. But those treated conservatively, only 9% of them has had the recurrence in the first 12 months. So draining the pneumothorax might even increase the risk of recurrence. So this is how I have been managing primary spontaneous pneumothorax for the last many years. This is a 21-year-old university student presenting with a first episode of spontaneous pneumothorax, non-smoker, no risk factors. As you can see, he presented with an almost complete right-sided pneumothorax. His presentation is mainly with pain, which settled in emergency with non-steroidals, and he was not particularly breathless. He was kept in the emergency department for observation for 4 hours, and the repeat X-ray was no change. So what do I do in this kind of situations? I examined him, he looks clinically well, and like what we have stated in the trial, we like to walk the patients around the emergency department. That is a very simple but very pragmatic test. If they walk with me, they talk to me, they're not restricted, they're not particularly breathless, and they can keep pace with me, then they're usually okay to be discharged. In Australia, because of the vast distances where people can be away from medical facilities, I need to establish that he lives near enough to the nearest medical center. He's got good understanding of the problem. We discuss all the options and we discharge him without any drainages. And this is his X-ray at presentation at day 4, day 10, day 28. And this is the final X-ray on the right-hand side. And as far as I know, he never developed a recurrence. And this is not the same case, and we have managed quite a lot of these complete pneumothorax with no drainages at all. And this is one of the recent examples that my juniors has written up as a case report. So the key points for primary spontaneous pneumothorax, most of them can be managed conservatively. Drainage is not necessary, and there are some hints to say that it might actually cause harm. Listen carefully to what the patient's symptoms are. It's usually pain and being anxious of not knowing what it is, rather than breathlessness. Analgesia is essential. Intervention will only increase the pain and makes the pain worse. But you need to conduct the safety monitoring because 15% of them will actually require chest tubes. And that involves having a chest X-ray in 4 to 6 hours time, showing stability, and all the vital signs are satisfactory. I need to emphasize that the evidence at the moment is only on primary spontaneous pneumothorax. But since the trial was published, there has been a lot of unprecedented interest in pneumothorax. There's lots of new hypotheses and debates. This is a pro-con debate in the American Journal of Respiratory and Critical Care Medicine this month, involving me and Nick Maskell's group. There has been a lot of new trials being planned at the moment to extend this conservative management to secondary pneumothorax, traumatic pneumothorax, iatrogenic pneumothorax after lung biopsy, etc. But I need to caution you that those are quite different categories of pneumothorax. And until we have evidence, I wouldn't advocate for that, because those involve patients that may have much more limited respiratory reserves. So at this point, I might just pause and listen to any questions and discussions.
Thanks, Gary. That was really comprehensive and interesting. Any questions? If you can raise your hand or post a question in the chat group. Maybe I can start while we're waiting for questions. You mentioned this, the serial chest X-rays with the conservative approach, and the 2 cases you showed, if I caught it, you went out to about 28 days on a chest X-ray. at what point, how long would you wait? And at what point would you say, well, this is not working and I need to do something different in terms of time frame? You know, how often do you do chest x-rays and how long do you wait it out? Thanks.
Yeah, I think that's a very good question. We are doing a little bit more x-rays than we probably should have, purely just for safety purposes, as I think there's still a lot of anxiety when we discharge patients with complete pneumothorax from our emergency department. I remember the first few cases I did that, our emergency doctors say that you must personally come down, sign your name, and say that you take full responsibility. And that's what I did. But because of that, we just be a little bit more cautious. And we're also a little bit academically interested to see how fast air get resolved. And so therefore we were doing a little bit more frequent x-rays than perhaps we should. We usually do chest x-ray until the lung is fully reinflated, but how frequently in between depends a lot on stability of the patient.
Right, and then how long, I mean, let's say you out to 28 days, you still have a significant pneumothorax. You know, how long do you go? Another 2 weeks? I mean, when do you stop?
Yeah, that hasn't quite happened to us.
I see. Okay.
I think once the air leak has stopped, even a complete hemithorax of air get resolved among that time. If there is still a pneumothorax significantly at that time, well, let me step back one step. If at any stage the pneumothorax got larger, that means that definitely has an ongoing air leak. And then that's something that we need to take seriously and might need to drain it. But if it remains stable, then it might just mean that there's still a small leak, but the rate of production equals the rate of absorption. And if the patient is asymptomatic, we tend to wait a bit longer. We also want, I guess there's one other situations where the lung might not fully expand, and if the lung is been trapped, and there's some other pathology going on that the visceral pleura is thickened. But I think that will be unlikely in a primary spontaneous pneumothorax. Yes.
All right, Gary, there's about 4 other questions. Maybe we can go through them quickly and you can give brief answers. Dirk Blom asks, how often should you repeat the chest x-ray, you know, in terms of monitoring these patients, you know, once a week or every 5 days or every 3 days? That's the question.
Yeah, so I think the most important thing is you must do another x-ray in 4 to 6 hours from the first one to make sure it is stable. We tend to do another one in a couple of days' time, but it all depends on how large it was. Obviously, if it is only a 1 centimeter apical pneumothorax, then I'll be a lot more relaxed to do it a little bit less frequently. If it was a complete pneumothorax like the one we have seen, then we'll be a lot more cautious and we'll do it a lot frequently. And it also depends on what's the rate of the re-expansion. If it's re-expanding nicely, then I'll do it a little bit less frequently. So there's no hard and fast rule. We make it up as we go is probably the honest answer.
Graham Menkes asks, what about the risk of tension pneumothorax using this approach? Any comments on?
Yeah, absolutely. I think that's the most concerning thing that people are worried about. Tension pneumothorax has almost never been reported in primary spontaneous pneumothorax when the lung is normal. Now, I need to emphasize one point. The definition of primary spontaneous, for tension pneumothorax is pneumothorax with hemodynamic instability, not mediastinal shift. Statistically, 9 out of 10 people with mediastinal shifts does not actually have hemodynamic compromise. So what is a real problem is the radiologist saying that the patient has got tension pneumothorax on the report, and then everybody say, well, you know, I need to then put in a chest drain. But we need to educate our radiologists, unless they come down and take the blood pressure and the pulse of the patient, they cannot really report tension pneumothorax. They should be saying pneumothorax with mediastinal shift, and then everybody will be a little bit more relaxed.
Okay, and there's 2 quick ones here, if we can get through them. Sipo Dlamini asked, does this approach apply to primary spontaneous pneumothorax, whatever the underlying cause?
I think primary spontaneous pneumothorax, by definition, doesn't have an underlying cause. So therefore, that is the case. And I think what you might be implying is that if the patient, say on the CT scan, has a lot of blaps, but the underlying lung parenchyma is normal. So far, that is still our approach, even though if it's got, lots of blaps on the surfaces.
Right. And then the last quick question, and this will be the last one,
Sure.
Peter Oppenheimer asks, like in your context, in our context, where transport back to the emergency room may be a major limitation, how many patients need to urgently return to the emergency room for management? What's your experience on this? Is that an essential requirement for discharge home?
In my experience, because I am still fairly conservative, even though to a lot of people I am very aggressive to sending even complete pneumothorax home. But if I have any concern, for example, if the patient lives quite far away, or if it is 11 o'clock at night, I would probably keep the patient overnight. But that would not be a reason for doing drainages. That would be just geographically keeping the patients in there. I think if you adhere to all the criteria that we have set down, then the chance of having to return emergency department returns is very, very low. Yeah.
Okay, great. I think we'll then move on then to the next part. Thank you.
Sure. Okay. So my next part is going to talk about malignant pleural effusions, which of course, as you know, is a major healthcare burden. And in the USA alone, that causes about 126,000 hospital admissions a year, with a median stay of 5.5 days. And the total hospital cost for management of malignant pleural effusion in the United States alone is more than $5 billion each year. And the most common method of managing pleurodesis is pleurodesis. And this is something that started in 1935. And over the last 100 or so years, we have made very little progress. But what we do know nowadays is that TALP pleurodesis success rate is suboptimal. So these are some of the large randomized trials involving TALP pleurodesis in recent years. And you can see the success rate is very consistent, around 70-something%. And don't forget that most of these trials selected patients who are not having a trapped lung, the lung fully re-expanded, and they don't have major comorbidities, etc. So the real life success rate of TALP pleurodesis in your or my practice is likely to be significantly lower than that. TALP pleurodesis can be delivered by dry powder prodrug, like medical or surgical thoracoscopy, or using TALP slurry, where the TALP is suspended in saline and instilled through a chest tube. There's been a long-standing debate as to whether one method is better than the other. And the new kit on the block is the indwelling pleural catheter, which I think you are starting to use also in South Africa. These are 15.6 French gauge silicone tubes, which are inserted between the ribs, tunnel underneath the skin. And in that tunnel portion, there's a polyester cuff, which will stick the catheter to the subcutaneous tissue so that you can eventually remove the stitches. And then it ends with a one-way valve where the patients can go home and connect themselves up to drainage bottles if and when they're short of breath. In the last decades, we've seen a significant rise in IPC use in all the Western countries. They now sell about 60,000 units of these in the United States. There's been a constant annual increase of around 20% in IPC use in the UK. So we've got three potential treatment strategies: surgical pleurodesis, TALP slurry through a chest tube, or indwelling pleural catheter. How do they compare? Well, there has now been 4 randomized trials comparing thoracoscopic TALP prodrug versus chest tube slurry, and none of them shows a significant difference in the success rates. So the old-fashioned teaching to think that TALP is more effective delivered by dry powder prodrug has now been quite convincingly disproved. This is the largest surgical thoracoscopic TALP prodrug study, and this is the Kaplan-Meier success rate, and you can see the two curves overlaps each other all the way. This is a recent publication in JAMA, which uses medical thoracoscopy or poroscopy with TALP prodrug versus TALP slurry, against no difference at all. So now there's been 4 randomized trials totaling more than 1,000 patients from UK, US, Hong Kong, and Brazil. and there's no difference between thoracoscopic talc paresis and talc slurry. What about talc slurry versus IPC? So these are two studies, one from Oxford, the Time 2 study, and one from us in the AMPLE-1 study. And what we found is that IPC reduces lifetime hospitalization time and also significantly reduced the number of invasive procedures they need after. So in the Time 2 study, the IPC patients show similar improvement in quality of life, in symptom benefits in terms of breathlessness and chest pain as compared with talc slurry patients. And in our study in Australia and New Zealand, 146 malignant pleural effusion patients randomized to talc slurry paresis or IPC, and we find that the total number of days they spent in hospital from the day of IPC insertion or chest tube insertion for talc slurry paresis shows a significant benefit for the IPC treated patients. Because of the significant difference in the lifespan of these patients, we express the number of days they spent in hospital as a percentage of their remaining lifespan. And you can see that the patients who was treated with talc paresis, they spend 11% of their remaining life to be in hospital for whatever reasons of hospitalization. But you can almost halve that to 6% if the use of indwelling pleural catheter. And this is another attraction for patients, those treated with talc paresis, because the success rate is only in the 70-something%, so 23% of them has to have further invasive drainage procedures. But very attractive to the patient is that once you fit it with an IPC, only 4% of them requires further invasive drainage procedures. But is IPC and talc slurry paresis two mutually exclusive options? That's what we used to think until Nick Maskell comes along with the IPC Plus trial, which combines IPC and talc slurry paresis via the catheter to try to capture the benefits of both methods. So this paper was published in the New England Journal, and it shows that the talc slurry installation through an IPC in an outpatient setting was safe, feasible, and efficacious. So compared with installation of saline as a control, those who have talc instilled through the IPC has a significant higher chance of achieving paresis, which is perhaps not surprising. But what is a discussion point afterwards is that the success rate of the paresis was significantly lower than what we usually expect for talc slurry through chest tubes. It was only in the 40-something% range. And this is almost certainly related to the fact that in the study protocol, IPC was only drained 2 or 3 times a week after the talc installation. And we do believe that if you apply aggressive daily drainages, it will increase the likelihood of talc purgage via IPC success rate. This is the latest American Thoracic Society malignant pleural effusion guidelines. Now, I want to draw your attention to some of the pickle answers in the guideline. So it says that large volume thoracentesis should be performed to see if the lung is expandable so that you can then decide whether the patient is suitable for paresis. So pickle 4 says that if the lung is expandable, IPC or chemical paresis like with talc can be used as first-line treatment. And in pickle 5, it says that if it is a non-expandable lung, then IPC is the best option. Then you can probably work it out that you should ask the question, why don't we then just use IPC as the first-line treatment? Because they can then incorporate all of the above and save the unnecessary procedures if the patients turn out to have trapped lung or failed paresis. So you don't then have to do a large volume thoracentesis to see if the lung expands or not. If the lung expands, you can put talc through the IPC. If the lung doesn't expand, you already have the IPC as your best choice. So to try to integrate all these very exciting randomized trials in the last 5 or 10 years into a single pragmatic algorithm, this is what our unit has been using, which is what we call the epitome protocol, which is early paresis via IPC with talc for malignant pleural effusions. So all the patients that present with a symptomatic malignant pleural effusions will by default have IPC as the first choice in my unit, unless there's contraindications. This is based on the fact that time 2 and EMPL-1 trial shows that it will minimize days patients have to spend in hospital, reduce further pleural interventions, and improve their quality of life and symptoms. We usually keep the patients in hospital. We do a chest X-ray when the fluid is drained dry, usually later on the day or overnight, to determine if the lung is fully reinflated or if it is trapped. If it is trapped, then IPC is the ideal option, and we discharge the patient on symptom-guided drainage. If the lung is fully inflated, we give TALC through the IPC using an inpatient TALC pleurodesis protocol, just like what you would normally use in your hospital for TALC slurry pleurodesis. This is a modified version of the IPC plus study. We can usually discharge the patient 24 to 36 hours afterwards, and we'll then perform daily drainage for at least the next 14 days. This is because the EMPL-2 study and the ASAP trials both shows that aggressive daily drainages improves pleurodesis success rate in IPC-treated patients. And in the EMPL-2 study, it also shows that that improves quality of life. And then if the drainages falls below a certain point on 3 consecutive drainages, and there's no significant residual fluid in the imaging, then the IPC can be removed. So we tested this algorithm in the first 100 patients, unselected consecutive malignant effusion patients that come through our unit. We put IPC in as the first choice, and then we find that half of those patients were not suitable for TALC pleurodesis because they have got trapped lung or if they have prior failed TALC pleurodesis. So we discharge them on IPC drainages, and over time, about 40% of those still developed a pleurodesis spontaneously. In the other half of the patients, we instilled TALC through the IPC, and we find that about 74% achieved a successful pleurodesis, allowing removal of the drain. And the median time to achieving pleurodesis is 20 days. The last remaining question is to compare the thoracoscopic surgical TALC pleurodesis with this algorithm that combines IPC and TALC slurry. And this is the subject of our current ongoing Australasian malignant pleural effusion, or EMPL-3 trial. We are now 87 patients as of today into the recruitment for 156 patients. And these are patients with malignant pleural effusion with a longer expected survival of at least about 6 months. So I'll pause here and answer any questions.
Okay, great. Thanks. So the first question is from Graham. Is there a maximum daily drainage amount advised? So, would you stop at a certain volume and then go to the next day, or
So we usually adhere to the rule that we would very seldom drain more than 1.5 liters through the IPC on a single occasion, because the data shows that the incidence of symptomatic re-expansion pulmonary edema will be larger. But in reality, what we really want to achieve is to try to keep the patient's symptom at bay, so that we keep the pleural fluid dry, or pleural cavity dry and free of pleural effusions. So we rather drain more frequently and try to keep the effusions at bay, so that the patient can enjoy the maximum capacity of breathing. It's quite uncommon, although not unheard of, that people drain more than 1.5 liters per day, but that's quite uncommon for pleural effusions. We do see that a lot of times for peritoneal effusions when we're putting indwelling peritoneal catheter, but that's a slightly different story.
Thanks. Can you comment on 2 things? How often do you see infection in your practice with these IPCs, and what about cost? Cost is a big thing for us here. The bottles, drainage bottles, are quite expensive. Some of the centers here use bags, and any comments about that approach and infection using that approach? Thanks.
Yeah. So the infection rate varies significantly from papers to papers. We actually published one of the largest IPC infection series, more than 1,000 patients from 11 centers, and the overall rate was about 5%. Now, that a little bit depends on your definition of infection. We only count patients who have symptomatic clinical infections. So I always say that indwelling pleural catheter is a little bit like indwelling urinary catheter. Sometimes you get colonization. If you culture the fluid, the patient can be entirely well, and we don't treat that as an infection. So we only count those who actually have clinical signs of infections that requires treatment, and that's around 5%. But it does vary from centers to centers. We have, someone has pointed out to say that why does the UK study and Australian study seems to have higher number of patients? That might be because that we do have more patients with mesothelioma that lives longer than the malignant pleural effusion from metastatic disease. And we do know that if you carry the IPC for longer, your chance of pleural infection will be a bit longer. But hopefully now with the talc pleurodesis, we can significantly shorten the number of days that people actually carries the IPC and reduces the infection risk. There are also quite a few studies at the early stage in our center to look at ways of preventing the infection. And maybe I can share that once we have a bit more data. In terms of bottles and expensiveness, yeah, that's absolutely true. The vacuum bottles are quite expensive, and it also can be potentially quite painful. So we actually use urine bags. So you need to have the adapter, and then we connect them to just a $1, $2 urine bags. And we were the first people in the world to use that approach. That puts me in the bad books of all the vendors because they earn a lot of money from selling you the bottles. But that's how we often use that to do drainages to cut the cost. Yeah.
Thanks. And then there's a question from Ricky Rain. Would you use a different approach depending on etiology, for example, mesothelioma versus carcinoma?
Not necessarily. We will use a different approach if the patient, for example, has a very chemotherapy sensitive malignancy. So for example, if they are EGFR positive, or if they got lymphoma, or even if they are early stage ovarian tumor, if the oncologist tells me that they're very likely to respond, then I would probably be a bit hesitant to use indwelling pleural catheter, whereas I would probably drain it dry on 1 or 2 occasions to try to give patients a bit of time for the chemotherapy to kick in. So that would be one approach, but otherwise not.
Yeah. Sticking on cost, Peter Robbenheimer asks, is there an alternative low-cost IPC available? I mean, what's the IP and patent situation on these things? Do you get low-cost versions or alternatives? So, not the bag, but the actual IPC. Thanks.
Not that I know of. In America, there are now 4 vendors, actually 4 manufacturers making IPCs. The cost has actually come down, at least in Australia. I think it's all driven by market forces, unfortunately.
Yeah. I mean, I would have thought
if you cut down the cost, if you count so all the economical studies has actually shown that by saving the number of hospital days, then it still actually turns out to be a more economical option, at least in Western countries.
Yeah. So, I mean, I'm just to weigh in on that. I mean, just, reasoning this out. I mean, there can't be any specific IP. It's a simple catheter. So I don't see any reason why, we can't. We do make some chest drain bottles here in South Africa. So I guess it will, just boil down to a manufacturer or someone designing one that we could use, here in Africa, I guess. What do you think, Gary?
Yeah, absolutely. I think that's anything to reduce the cost will be good for patients. Yes.
There's another question here on the lifespan of an IPC catheter.
As long as the patient, yeah. So the longest we have had is about 3 years. but it is designed to last for as long as the patient requires drainages.
Okay, great. Okay, I think that was a really good discussion. Maybe we can move on to the last part, Gary. Thanks.
Okay. So last but not the least, I'm going to talk about pleural infection, which is obviously a significant healthcare burden. This nationwide analysis from the US say that it causes about $100 million in the US each year. The median hospital stay is around 19 days. The cornerstones of treatment has not changed for decades. You need to evacuate the infected pleural fluid, usually through chest tube, fibrinolytics, or surgery, and to control the infection through antibiotics. This is a landmark MIS2 study published in the New England Journal more than 10 years ago now, and it shows that it significantly reduced the X-ray opacity if you use the intrapleural TPA and DNase combination treatment. It also reduced the need for surgery and reduced the hospital stay. This is a recent Lancet Respiratory Medicine expert consensus statement that suggests that you should use intrapleural fibrinolytics and DNase, but not just one of the two agents. The recommendation was still based on MIS2 protocol at that time, which is TPA 10 milligram, DNase 5 milligram twice daily. The number of doses you need to use should be individualized based on clinical, radiological, and inflammatory marker response. Correct the underlying coagulopathy and withhold anticoagulants therapy if possible. And it should be the first-line treatment before surgery in fibropurulent cases. In patients with chronic empyema and their thick pleural rind, I guess the jury is still out for that. So one of the ongoing research topic in my group is to try to find the optimal dosing for TPA and DNase. Just following on the conversation that we just had about costs, concerns about TPA is about the cost and also the risk of bleeding, especially in elderly people with comorbidities. So the initial dose of 10 milligram of TPA was entirely empirical. It's never been subjected to a phase 1 dose escalation study. So finding a minimal effective dose will have benefits. So this is one of my favorite papers on TPA use, which is actually in the veterinary journal. So the vets has been using TPA to treat horses with pleural infections. And in 400 kilogram type horses, the median effective dose they found was about 3.7 milligram. So treating our human patients with 10 milligram doses is likely to represent a significant overdose. So we started the Alteplase dose assessment for pleural infection therapy, or ADEPT studies, which is a systematic dose de-escalation series. We started with the largest open label series using 10 milligram of TPA in more than 100 patients who failed simple drainage and antibiotics treatment, and confirming the benefits as shown in the MIS2 randomized trial. And then we go down to 5 milligram TPA and shows that the success rate is still over 90%. And many centers are now using that. And we have just last month published the 2.5 milligram series using 2.5 milligram of TPA as a starting regime. But obviously, if the patient's clinical response is not right in the next day or two, then you escalate to higher doses if clinically needed. And the success rate was still around 90%, which is by definition survive to discharge with no need for surgery. And part of that unsuccessful rate was some of these patients has underlying cancer and actually died as an inpatient. But most of the patients shows radiographic clearance, increased pleural drainage, and reduction in their CRP. 17 out of the 69 patients required dose escalation, mostly trying to break distant locules and avoid more chest drains. Median 5 doses were used. 2 out of the 69 patients required blood transfusion because of some level of pleural bleeding. All of them are hemodynamically stable. We've also recently published the only long-term follow-up study for patients who was treated with TPA and DNase at least 12 months ago. None of those patients has a recurrence of pleural infection. All of them returned to previous employment status, and all of them say that if they have ever got empyema again, they're more than happy to have TPA MDNAs again. And most of them did not have any long-term complications from the pleural infection, no significant residual pleural thickening, and quality of life instrument shows a satisfactory rating. So how I manage patients with pleural infection at this day and age. This is a 42-year-old man who has been unwell for a few weeks because all his young children at home has been sick with respiratory tract infection, and he presented with fever, left-sided chest pain, and on the chest X-ray and CT scan, you can see multiple loculated pleural collections. So the step one is antibiotics. It's very important to find the optimal antibiotics that cover the common organisms in your region, and also to make sure that you're using antibiotics that has good pleural penetration. And of course, the next step is chest tube drainage. We always use ultrasound these days. So in this patient, 18 French gauge cell linear drain by ultrasound to the lowest pocket, which cleared the pocket. But as you can see that he's still got some collections. So if the infection persists, which means that the fever is still there, the inflammatory markers like white cell and CRP is still high, despite optimal antibiotics and drainage, that's when we start intrapleural TPA and DNAs. So in this case, we got 2 doses in, and you can see the mid-zone collection is completely cleared, but the apical collection has persisted. So in this case, it's unlikely that the TPA and DNAs further doses will make a difference. So we put in a ultrasound-guided small 12 French gauge drains at the bedside into the apical collection. And we then put in 2 doses of TPA and DNAs through that chest tube into that particular collection, and you can see that's a very good result. So this patient was admitted on March 12, first chest drain in on March 13, and by March 17, you can see a very good clearance. And this is his CRP pattern, and you can see a very good clinical response. Surgery nowadays in my unit is very rarely used for pleural infection. Is only for those who have significant contraindications for TPA or DNAs, or in the small percentage of people that fail the treatment. Just to finish this section, this is Sir William Osler, who we all know is the father of modern medicine, but maybe you don't know that he actually suffered from an empyema, and at which time he said empyema needs a surgeon and 3 inches of cold steel instead of the fool of a physician. And most of the literature would tell you that Sir William Osler died from a protracted course of empyema. But recently, on the 100th year of Sir Osler's death, we were asked to contribute one of the articles in an invited review series on Sir William Osler's empyema. So we went through a large number of his history articles, and we find that Sir William Osler underwent rib resection and surgical drainage. He actually died at day 5 postoperatively from massive pleural hemorrhage. So we like to correct the history that Sir Osler didn't exactly die from the empyema. The pleural infection didn't kill him, the surgery did. So in 2022, if he comes to our unit, he will be given TPA and DNAs. He's very unlikely to require surgery, and he would probably have survived the empyema. If I can just have 1 or 2 minutes, I'm going to quickly show you a couple of examples of how research can be fun and change practice, if I can. So one of these examples is every day when we look at the chest tubes, we often see these clumps in chest tubes. And I'm sure you have seen many of those before. And clumps often block off the chest tubes, and we used to curse them and see them as nuisance because we now need to clear them and flush the tubes. But we one day sit down and ask ourselves, what exactly are these clumps? Are they pieces of pleura? Are they clots? What are they? So we start this simple project that we do on our ward rounds and collect clumps from 20 patients with known cancer who develop pleural effusions. And we send it to our friendly pathologist, who then analyze the clumps for us. And then they find that these clumps are organized fibrin clots, but they act like a fish trap. They let the fluid to go through, but captures the cells. So in 15 of those 20 clumps, we actually found malignant cells. 12 of those patients, the pleural fluid cytology was positive, but in 3 of them, the pleural fluid cytology was actually negative, but they have got cancer cells identified in the clumps. So we no longer see the clumps as nuisance, but we actually see it as a very non-invasive way to get free diagnostic material. Another fun study we have done recently is the AIR study. So very often in pleuroscopy and thoracoscopy, we see multiple nodules on the pleural surfaces. But these nodules are never seen on the CT scan easily beforehand. But we know that CT scan can detect a lot of parenchymal lung nodules, down to 1 millimeter nodules, which we often don't want to see. But why can't they actually detect these small these small pleural nodules? So our hypothesis is that the density of the visceral and parietal pleural and the pleural fluid is too similar. So you need to have a media that is a slightly different density, and air would be a perfect example. So in this proof of principle series that we published in CHEST, all these patients do not have a visible pleural abnormality on their pre-drainage CT scans. But all these patients has got air in the pleural cavity, usually because of trapped lung after drainage. And you can suddenly see multiple nodules that you couldn't see before on the CT scan. So the sensitivity of CT scan to detect pleural abnormality significantly increases if you got some air in the pleural space. So one of the fun projects we have been doing is called the AIR study. In patients who have got the chest tube and the IPC placed already in the pleural space, if they're going through a CT scan, we inject 500 mils of air through the tube and just clamped it for that very, very short time to take a CT scan and open up the tube afterwards to demonstrate the safety, feasibility, and increased detection of pleural nodules having a bit of air as a extra media in the pleural space for CT scan. And so conventionally, we see air in the pleural space as an undesirable feature, but we are testing whether air can be a safe pleural contrast medium in this particular study. So very briefly, I think all the research we have shown today shows that recent research has made a major impact on how we drain pleural fluid. But what we needs to get up to the next stage, rather than just being a good plumber, is to rely on us having translational research to understand the biological roles of pleural diseases so that we don't lose sight of the ultimate goal, which is to stop the pleural effusion formation in the first place. I'd just like to thank my clinical and laboratory research team for the hard work that generates a lot of the data that you have seen today. And thank you for your attention.
Thanks, Gary, for that really fascinating last part of your lecture. We've got some questions here. I mean, there's a couple of questions. Maybe we can get that out of the way. We've been talking about this in our unit for some time, and the obvious question is, DNAs and TPA for TB pleural effusion. Maybe you can comment on that, whether there have been any preliminary studies. We see a lot of TB pleural effusion, and we see these locules of fluid lingering on even after patients have gotten better for months, if not years. And we also see substantial pleural thickening in some individuals. Any comments on TB and DNAs and TPA? I'm not aware of any studies, and
I think therefore you will be in a prime position to actually do something to test that.
Yeah, well, maybe that's something we can collaborate on. So there was a bunch of questions on that from Shiraz and Peter. And then Graham, what indications do you use for going directly to surgery rather than the TPA DNase approach? When would
very
you
seldom, very seldom now, because you need to put in a chest tube. Often, I don't know in your unit, but in most other hospitals, I would think that surgery may not happen immediately. So why not try TPN-DNAs? And because statistically we have a 90-something% chance of success, and so therefore it is very seldom that we require surgery. So the cardiothoracic surgical trainee in our hospital consistently fail their training quota for surgical decortications for pleural infection, because we so seldom require surgery. And the surgical department has a standard letter to the Royal College every year to say, Gary Lee works here, what else can we do?
Another question is around antibiotic. And I mean, you've got the classic situation of a PK mismatch here where you got, you know, no vascularization of the space you want to get your antibiotic into. And can you comment on studies and, you know, antibiotic levels in these pleural locules, and what you know, comment on antibiotic choices from your experience? Thanks.
That's a fantastic question, because if the two cornerstone for pleural infection treatment is drainage and antibiotics. And I often ask the audience, unfortunately, obviously, we are not face-to-face, but if you think about it, if you only can have one, which one will you have? I would have antibiotics, not drainage. And yet, you can see if you do a Medline search, 90-something% of all the studies in pleural infection is about how to drain the infections. And very, very seldom has any studies look at pleural infection and antibiotics. So we are very fortunate to have a couple of pharmacists in our unit doing PhDs on them. But I can tell you that on the literature search, if you look at any kind of penicillin-based antibiotics in clinical studies, there has only been one paper that has more than 10 patients to look at the pharmacokinetics. It is what we call an evidence-free zone. So we do know that some antibiotics, such as gentamicin, don't work in acidic pH, so we try to avoid that. And it is very difficult to know how much of the antibiotics actually enters into the pleural space. We actually developed a tarsalsin assay, which is tazobactam and piperacillin, which is one of the most common antibiotics we use for pleural infections as a starting point. And we actually find that most of the patients in our small series do reach the MIC with the tarsalsin levels, but they don't reach the 4 times MIC, which is what the guidelines would say that you want to achieve in the target antibiotics levels within the pleural fluid. But of course, there tend to be huge variations, depends on your pleural thickness and a lot of other host factors as well. So I think that is yet another very important topic. Yeah.
And just in your clinical practice, any sort of comments on dose that you would use? I mean, do you use a higher dose? Or
no, we tend to stay with the same doses. And I think like in the BTS guidelines, then another antibiotics that's quite useful is clindamycin that we trust. But this is kind of more anecdotal rather than to say that there's any concrete evidence to support that.
Okay, there's a question here from Ali Ismail. Does TPA DNAs work for more chronic effusions? Is there a time cutoff?
That is a difficult one. I guess in the centers that has done all the TPA and DNA studies, we don't necessarily see a lot of the very chronic empyema that sometimes happens in other parts of the world, maybe in South Africa. So we don't know. So the Lancet Respiratory Medicine statement was very cautious that for people with very established pleural rind, the jury is still out and there might be a role for surgery in those cases. But I think in those cases, there's probably no harm in trying TPA and DNAs if they're not acutely ill. That's been a chronic situation. If it just works, then that might still spare the patient some risk of surgery. Those surgery are not simple or straightforward. I often try to go and see the surgery of my patients whenever possible. And I don't know how many of you might have actually attended some of these surgical procedures. They are actually quite difficult, and very often decortication is extremely difficult, and causes air leak, etc. So they're not straightforward procedures. I'm not sure if I have lost Keaton.
Yeah, yes, it looks as though Keaton's disappeared off the radar along with the whole of the Department of Medicine. So perhaps I can just thank you on behalf of the Division of Pulmonology. That was an absolutely fascinating lecture, probably going to change our practice, probably because we've been operating quite a lot on the sort of anecdotal level rather than the scientific level. And obviously we see a huge number of TB effusions, both acute and chronic, and there must be a very rich potential source for research, which you've been neglecting up to now. So I'd like to thank you very much. It's a magnificent presentation.
Thank you.
I just lost, I don't know, I seem to have lost reception here. Am I back on, Gary?
Yes, you are. Yes.
Okay, I've just connected on my phone. I don't know if others have also lost the connection. Okay, I'm not sure where I got back on. Are there any other questions, Gary, or not sure what's...
Hi, Keaton. Probably not. It doesn't seem that any more questions have come through, and I just sort of mentioned that we have a very, very rich potential source with all the TB pleural disease we have that could keep people with Gary's interest busy for a very long time.
Yes. Now, Gary, I just had one, I mean, if I may, I just had one last question. This is concerning bronchoscopies and transbronchial biopsies. What we've been doing is doing, we have ultrasound handy now, so we do an ultrasound before the procedure and after transbronchial biopsy, looking at the sliding sign. Any evidence or any comments on that? Is that something that there's studies on, or that you'd use in your clinical practice?
I don't have to do a lot of bronchoscopy these days, but I think a lot of centers with the right level of ultrasound expertise is quite happy to do that. But I think you absolutely hit it at the right spot to say that you need to do it before and after the procedure, because ultrasound, strictly speaking, for pneumothorax is quite tricky. And Professor Gleason, who is probably one of the world's best chest radiologists, professor of radiology in Oxford, has published a whole series of doing ultrasound to look at pneumothorax in respiratory patients. And he shows that even in his hands, there is an error rate, especially with people who've got chronic lung disease, especially COPD or cystic lung diseases, so large bullae, bronchiectasis, etc. And it shows that when he compares himself with his trainees, then the trainees has even higher error rates. So if your pre-test probability is that the patient has got abnormal lungs, then the loss of gliding is quite a dangerous thing to use that to determine pneumothorax. So in the transbronchial setting, you're absolutely right. Therefore, you have to do the pre-procedure ultrasound so that you know what it looks like beforehand, and then whether that is a new change of loss of gliding. So I guess if you don't have gliding to start with, then you obviously cannot use that as a tool to check afterwards. So this is quite different, and we often have to emphasize it on ultrasound courses that this is quite different from what the emergency doctors are often doing in their fast scans protocol for trauma patients to look for pneumothorax. Because in those otherwise young and fit persons, when the pre-test probability of a lung abnormality is low, then the loss of gliding in that situations might suggest that you might have a high chance of a traumatic pneumothorax. But in your respiratory patients, that you need to be extremely cautious in using lack of gliding. And the more we learn gliding, the more we know that it's quite tricky. If you ultrasound the patient lying down, they have less gliding in the same spot than is sitting up. If it's apical areas, they have less gliding than the basal areas.
Okay, great. Thank you. Are there any other questions from anyone? Okay, great. So I think thanks. I think we'll end there. Gary, thanks for your very thoughtful lectures, and you covered a substantial amount of material, very interesting. And we hope to invite you back sometime, and also to see you sometime in South Africa. And good night, and thanks for availing yourself so late in the evening. We're really grateful. Thank you so much.
Pleasure. See you later.
Bye-bye.